So guys, I'm going to start sharing my screen and let me know if you can see it. Is that okay?
Yes, we can see it.
Okay, thank you. So we already talked about hematology, right? And bones, which would be about orthopedics, right? And some other specialty. I don't really remember which one it was. However, the next one would be the endocrine system, and I chose this important topic, which is hypothyroidism. Okay, so if you have any questions, mainly about pronunciation, because I know you, well, I know you can handle this kind of knowledge, and that you already have it. So let's get started. Here's a table of contents that we're going to discuss today, which are mainly three: anatomy and histology. We're going to talk about the basics and most important features about each one. Okay, I mean each subject, related, of course, to hypothyroidism, physiology, some basic and most important concepts related to it also, and we're going to talk about the disease itself. Okay, related to pathophysiology, symptoms and signs, and treatment. Okay, so we're going to start with some basics in anatomy related to this gland. Okay, so this organ is actually a gland, right? This is the biggest endocrine gland of the body. It has, as you know, two lobes. Could you give me 1 second, please, guys? Okay, so this is the biggest endocrine gland of the body. It is actually responsible for producing, as you know, these hormones T3 and T4, right? These hormones are related to some components when we're talking about homeostasis. Okay, this its name is actual comes from the thyroid cartilage, right? Which is related to the larynx. Uh, Actually, it comes from two words. One of them is thyreus, which means shield, right? And eidos, which means shape. So it is an organ that has the shape of a shield, right? It actually, when we talk about embryology, you all know that this organ actually comes from well, it's like has some it's like a freeway, right? Which starts at the base of the tongue, right? And the foramen cecus, right? Which in Spanish would be agujero ciego, foramen ciego, right? This one is located at the base of the tongue, and it goes through the neck down to its final location, which is which would be between the sternum and the thyroid cartilage, right? This, let's call it freeway, right, is actually called the thyroglossal duct, which we're going to talk about later on. Okay, so as I was telling you this, you already know this. This organ has actually two lobes, a right and a left one. In the middle of both, it has an isthmus, right? And here we have another lobe, which is not constant. It is like an anatomical variation, right? Which is the pyramidal lobe. There was a mistake right there. I'm sorry. And The whole gland has a weight of from 10 to 20 grams. Okay, and this is important for your general practice that you're going to have later in your lives. And why is this important? Because when we ask for an ultrasound test of this organ, we're going to have the report. Uh, it could be in two main ways. Okay, Oh, a doctor could have write his or her report based on the weight of the gland. Okay, or based on the size of the gland. However, it is more common to have it reported related to its weight. Okay, so when, for example, when there is when our patient has this diagnosis, which is hypothyroidism, right? It would be it would have a lower weight than expected. Okay, for sex, for age, and some other variables that we're going to talk about later on. So it could also be reported as times. Let's say, for example, a gland that is, for example, 60 grams would actually be 3 times bigger than usual. So it will be reported like 3x, okay, which would mean 3 times bigger than usual. However, the most common way uh, is to have it reported related to its weight. So from 10 to 20 grams is the regular size or weight according to its size, right? So if we have it reported in according to the size, the normal ranges are 4 centimeters length, right? 2 centimeters wide, right? And 1.5 to 2 centimeters thick. Okay, so this is actually one of the important things to have always in mind when we're talking about this gland: the weight and the pyramidal lobe. Okay, so as I was telling you, this organ actually starts its freeway at the base of the tongue, the foramen secum, right? Then it goes down, straight down to its final position. As you can see, sorry, I'm going, okay. As you can see it, reaching its final position. However, there could be some um, conditions in which this migration, right, does not happen correctly. So what would it happen? Since it would stop here, right here, we would have a different kind of thyroid, which would be a sublingual thyroid. Okay, if it keeps going down and at the end of the its final position and has remainings of this duct, which is the thyroglossal duct, we would have what we just saw here. It would be the pyramidal lobe. Okay, so in some cases we can find sublingual uh, thyroid, which happens due to some failings in its migration. Okay, and in most cases, this is actually called sublingual thyroid, right? And it's in most cases, this sublingual thyroid is actually completely functional. It is functions quite normally. Okay, it is actually an anatomical variant which would be considered normal, of course, according to its function. It is not the regular position, however, it is completely functional. And what happens when we find this, especially in the midline of the neck? It would, well, we would have to think about a thyroglossal cyst. Okay, this is here down under the tongue. We would have the sublingual thyroid, right? If it keeps coming down, however, it does not reach its final position, which would be right here, right? And it stops here, upper than usual, we would have a thyroglossal cyst, okay? But if it stops coming down at the base of the tongue, then we would have a thyroglossal cyst. Can anybody tell me what kind of study this is on your right? Even in Spanish?
Tráquea.
Sorry, who was talking?
Tráquea.
What kind of study? This is actually a study, an image study on your right. The image on your right is a study. In Spanish, does anybody know? Okay, I'm going to, well, it's actually, this is, in Spanish, it's centellografía tiroidea. Centellografía, right? In English would be scintigraphy. Okay, so what happens? Well, we actually have our patient with, well, we give our patient a contrast based on iodine, okay, based on radioactive iodine. And when, as we're going to talk about later on, this gland actually binds to this iodine, and we have like an x-ray, okay? And since well, this gland is binded to this iodine, here's the result. I mean, this is actually the normal thyroid, and and this one above the normal one would be a sublingual thyroid, okay? Because it is like drinking the regular binding to iodine. Iodine means yodo, okay? So this normal tissue, this gland actually binds to iodine. So what would be normal is this image down here, because this is the normal position of the gland, right? However, since we might have a failure in migration of the gland, this gland tissue would also bind to iodine, okay? And this is called a sublingual thyroid, okay? These are completely functional. Both thyroglossal cyst and sublingual thyroid are both functional. This tissue and this one are functional, actually work as usual as the thyroid, the normal or regular thyroid would. Okay, so we're going to take a closer look here. This gland is actually formed by a lot of these structures, which are the follicles. As you already know, these are follicles, and they are made of this kind of cells, which are the follicle cells, or follicular cells. Okay, this one, right? Inside of this follicle, we have this substance, which is the colloid. In this substance, which is the colloid, we actually have our hormones formed. Okay, and next to the follicles, we have some other types of cells, which would be, for example, the parafollicular cells. Okay, and actually, there's a few more. Well, this one, the parafollicular cells are actually also called C cells, and these cells produce another kind of hormone. Does anybody know what kind of hormone this parafollicular or C cell forms or produces? Okay, it actually produces calcitonin, okay, related to the metabolism of calcium and phosphorus. Okay, so mm, as well, these are the basic knowledge for you to understand the next part, which is the physiology. Okay, so as you know, there's an axis, right? We also talked about it. I don't know which class, however, you already know this. The hypothalamus, does anybody know what two main nucleus of the hypothalamus are related to this axis? Anybody, guys? What are the nucleus? There are two nucleus that are related to this axis. Supraoptic nucleus and paraventricular nucleus. Okay, both nucleus produce one hormone, which is this one, the TRH, right? Thyroid uh, releasing hormone. Okay, and this is released into the pituitary gland, and mainly the anterior lobe, right, which is the gland part, let's say, let's call it that way, of the pituitary gland. Okay, so this hormone is released and then goes to the anterior lobe of the pituitary gland, and this actually has one kind of cells that produce this this other this another hormone, which is the TSH, right? Thyroid stimulating hormone. Okay, and this one stimulates, as its name says, the gland, and makes it produce both hormones, T3 and T4, right? Its levels, its concentrations levels increase in bloodstream, and this increased concentrations of the hormones are actually sensed, like yes, they're sensed by these two structures, which are the hypothalamus and the pituitary gland, and make it's like a break, right? They make them stop producing the first hormone, the TRH. Does anybody know what this is? What kind of mechanism this is?
Retroalimentación negativa.
Okay, yes, in English, okay, you're right. It would be in English, negative feedback mechanism, right? Okay, so it makes this increased levels of both hormones, makes both through this negative feedback mechanism to stop producing these other two hormones, TRH and TSH, right? You already know this. So How, well, we got to this part, right? This TSH makes the gland produce both T3 and T4 hormones. But how does this happen? That's what we're going to take a look at next. So these are actually the cells that we were talking about. And these are the follicular cells, right? So how does the produce? How does this kind of cell produce this both hormones? These cells, these follicular cells, actually have two main poles, right? One basal pole and one apical pole. Okay, this one is actually related to the colloid, right? And the basal uh, pole is actually related to the capillaries. So most of the chemical reactions take place in the apical pole. Okay, and here we have a really important enzyme, which is the TPO, thyroid peroxidase. Okay, in Spanish, tiroperoxidasa, right? This is the one. Okay, it is located. Remember, it's located actually in the apical pole of the cell. So there are actually two main types of thyroid hormones. The T4, right, which is thyroxine, right, and the T3, which is actually, well, it stands for the number of iodine molecules that it has. So T3 actually has three iodines, right, and T4 has four iodines. They're both formed by a process in which we have actually a main amino acid, which is tyrosine. Okay, and mm, well, and this cell takes this amino acid and makes a protein, which is the thyroglobulin, TG. Okay, so this is formed by a tyrosine residual, which is an amino acid. Then we have this protein, and this cell through the TPO takes the TG to the TPO, and the TPO actually has three main functions. Okay, one is to oxidize the iodine with some components. So oxidation of iodine would be the first function of the TPO. The next one would be to, let's say, like locate some iodine residuals into the TG. Okay, so we have the TG itself, and the TPO adds some iodine residuals, and there we have some iodine tyrosines, which are MIT and DIT. MIT with one single iodine and DIT with two. Okay, so after that happens the third function of the TPO. Takes one MIT and takes one DIT, and then we have three iodines, right? This one had one, and this one had two. It's like this molecule, the TPO, puts them together and creates a T3, right? If this TPO takes two DIT, then we have four iodines, right? And then we have the T4. It is only related to the amount of iodine residuals. So we have this T3 and T4 binding to the TG, and it is like saved inside the colloid until it is required by peripheral tissues. So these hormones are like saved inside a TG, right? And some small port, when there's a stimulation in which this cell starts working, what happens next? Some portions of colloid that includes this whole molecule, this big molecule, is taken inside the cell, and it is actually going through this protein, which is pendrin. Okay, in Spanish would be pendrina. Okay, so takes this little portion of colloid, including this molecule, and makes it go through this pendrin molecule to go inside the cell and then go to the capillaries. There's actually a disease in which this molecule is absent. These patients might not have this kind of molecule, which is the pendrin. And does anybody know what syndrome this is, or what this syndrome is called? The lack of pendrin? Okay, this molecule actually, well, its name comes from a person who described it first. Okay, this person had a last name which was Pendret. Okay, this person's last name was Pendret. So this molecule is called, well, was named after this person. So Pendrin is related to the last name of this person, which was Pendret. So the disease or the syndrome we're talking about, or I was asking you about, is actually Pendret's syndrome, syndrome de Pendret. Does anybody know what kind of features, clinical features this disease has? Okay, so
Some
yes.
mutation.
Okay, there's actually, yes, a mutation of the chromosome related to the pendrin, right? Yeah, so this patient has some sort of mutation in the chromosome related to this protein, and it does not go to the surface because it's like a failed molecule. And what would this patient have? So this whole molecule couldn't go inside, or wouldn't be able to go inside the cell, and therefore wouldn't be able to go to the bloodstream, right? So this person might have an increased concentration of iodine inside the gland, but this would this person would also have decreased concentration of iodine and T3 and T4 in the bloodstream, right? Because it's like trapped inside the gland and cannot go through the cell to the capillaries. And it doesn't, of course, does not reach like the peripheral tissues. And it is also related, therefore, to hypothyroidism. Okay, so Pendret's syndrome is related to hypothyroidism. Okay, one type of hypothyroidism would be related to Pendret's syndrome. Okay, so as you know, we have this both forms of this of these hormones, it's like T4 and T3, right? As you know, T3 is actually the active form, and T4 is actually a reserve form. Okay, so we could say that T3 is actually inside a T4. Actually, there is like a basic knowledge which tells us that 80% of the T3 levels actually come from the T4. Um, it's like transforms into T3. Okay, so actually, most part of the T3 molecules come from T4. Okay, it is actually that is why actually T4 has well, for every 20 molecules of T4, there's only one T3. So there's a lot of more T4 molecules rather than T3 molecules. Okay, so it goes, well, let's say this both hormones are released into the bloodstream, right? And they have to reach the peripheral tissues, right? For them to take action. So in peripheral tissues, there are some enzymes that are related to the metabolism of these hormones. As I already told you, this T4 is actually a non-active form, and the active form is T3, right? So that's, well, this peripheral tissues have this three types of deiodinase, deiodinase, which are some enzymes that like take away one iodine molecule, and since it had four, right? Talking about the T4, we diminish this one molecule of iodine, and then we have three iodines, right? The active form of the thyroid hormones. So we have three main types, which are type 1, type 2, and type 3, the iodinase. So type 1 turns T4 to T3, and type 1 is actually located in the liver and kidney. Okay, so makes the T4 transforms into a T3 molecule. Type 2 is in the central nervous system, and like greasy tissue. Okay, and it also transforms T4 into T3 molecules. And here is something interesting. Type 3, where do you think type 3, this type of enzyme is located? Does anybody know where this type of enzyme is located? Okay, so type 3 is actually, well, let's imagine a patient, a female patient, okay, a woman that is actually pregnant. Okay, so we have this pregnant woman, and we have, of course, the baby inside of her, right? So, what would happen if the hormones that are produced by the mother go into the bloodstream of her child? This child, this baby, this non-born baby would have hyperthyroidism, right? Because of the amount of thyroid hormones of the mother, right? So This type 3 enzyme is actually in this organ. So this is a placenta, right? So the blood would go through the vessels, reach the organ, and this organ has the type 3 enzyme, okay, and turns the T4 into a different type of T3. The type 1 and type 2 enzymes take away one iodine, as I told you, right? But they take away an iodine from one specific position, which is the fifth position. And this one takes away also one iodine, but it takes a different position iodine. So it turns the T4 into an RT3 molecule. What does R stand for? Does anybody know what this R stands for? Okay, this actually stands for the word reverse. Okay, so this molecule, this resulting molecule is actually a reverse T3. In Spanish, T3 reversa. Okay, so what is the difference between RT3 and T3? This one's right. Is that this reverse T3 is actually non-active, a non-active form of the molecule. So when the hormones, the mother's hormones, go through the placenta and reach this organ, these hormones are actually deactivated by this organ, and when they reach the bloodstream of the baby, they do not have effect because they were inactivated. Okay, so type 1 and type 2, we have an active form, which is the T3, right? And type 3 gives us the reverse T3, which is not, which is a non-active form of the hormone. Okay, so there's like a percentage of hormones that are actually free and bound hormones. Does anybody know what kind of molecules it binds to go through the bloodstream? There are three main molecules. Come on, guys, I know that you know this kind of things. Even in Spanish, can anybody tell me? Does anybody know what the TBH is? Thyroid binding. Come on, guys. Thyroid binding globulin. Okay. And the other two, what is the main, well, the most, well, the molecule that is has the highest concentration inside the bloodstream? Come on, guys. Some other days you were able to answer. I know that you can do it now. Albumin and prealbumin. Okay, so this albumin, prealbumin, and TBG, right? These are the three main molecules to which this both hormones T3 and T4 bind to to go to the through the bloodstream, reach a peripheral organ, and happens what I already told you, right? This one, these reactions. Type 1, type 2, and type 3 enzymes have, as I told you, different kind of actions. Type 3 gives us reverse T3, and type 1 and type 2 gives us um, T3, which is actually the active form of the hormone, right? Also, this one, the type 3, takes away another iodine molecule and gives us the T2, okay? To deactivate this active hormone, which is the T3, there's actually this type 3 enzyme takes away another iodine molecule, and there we have a T2 molecule, which is also a non-active form of the hormone. So hypothyroidism, what is it about? So can anybody read this since you're not participating that much today? Let's see. Mm, Constanza, I haven't seen you in a while. Could you read this? Constanza, are you there? Okay, guess she's not. Let's call another student. Diana Gonzalez, are you here?
Yes, hi.
Yes, I'm going, lady.
Okay, so could you please read this?
Sorry, tired doesn't begin to describe the debilitating exhaustion.
Exhaustion,
Exhaustion. Uh, I don't know
Thy-
how to
thyroid,
thyroid disease. And disease can cause. I'm not lazy. I'm sick. Please try to understand this.
okay, thank you. So this kind of describes the clinical feature, the main clinical feature of a person who has this kind of diagnosis, right? Which is hypothyroidism. Most people with this diagnosis actually feel really tired most of the time, right? Sorry. Okay. So hypothyroidism, how can we mm, relate it to some sort of classification? We have a primary hypothyroidism, right? Which is related to the decreased uh, function of the thyroid, okay? And it is actually most part or represents most part, around 90% of all the cases of hypothyroidism. Then we have a secondary hypothyroidism, which is related to the decreased function of the pituitary gland, okay? And then we have a tertiary hypothyroidism, which is actually related to a decreased function of the hypothalamus, okay? This is primary, the most common one, and secondary and tertiary are actually also called central hypothyroidism, okay? So when the failure is in the thyroid gland, we have a primary hypothyroidism. If the failure is in the pituitary gland or the hypothalamus, it is actually a secondary or tertiary hypothyroidism, also called central hypothyroidism. There are some different causes of hypothyroidism. For example, autoimmune disease, which would be related to Hashimoto's disease. Nutritional A nutritional cause would be related to iodine deficiency. Uh, Here in Bolivia, we have a lot of this, especially in La Paz, Oruro, and Potosí, right? Does anybody know why? Come on, guys, participate a little more. You're too quiet today. Does anybody know why um, and a nutritional cause is related to iodine deficiency and why this is related to more cases here in Bolivia and especially in the western part of the country, which would be La Paz, Oruro, and Potosí? Bolivian guys, come on. I mean, in El Salvador, I don't think they have this kind of deficiency, right? Here, especially in my region, there's more cases actually than at sea level or lower altitudes. Bolivian guys, come on. Okay, I'm going to make you participate. So, Bernardo,
Hi, doctor.
okay. Hey, do you know why iodine deficiency is more present here in La Paz, Oruro, and Potosí?
Uh, because in the food we don't have iodine,
Iodine. It's,
iodine,
okay, but why?
because we eat more uh, potatoes and things so like that.
Okay. Okay, iodine is actually in the ground, right? It is, yes, in the ground. So since we are in higher altitudes, this ground actually goes down, right? So it is iodine is actually more concentrated at sea level. At high altitudes, since iodine actually goes down, at high altitudes, there is not a lot of iodine concentration in the ground. So some products that actually have more iodine concentration at sea level, at higher altitudes, we do not have that much concentration. Okay, can anybody pronounce this word? We all know what it means, but in English, could you um, tell me how it is pronounced? How would you read this? Iatrogenic. Okay, so it would be caused by a radioactive iodine therapy, complete thyroidectomy, and radiation. Okay, so these treatments would actually cause hypothyroidism due to the destruction of the cells of follicular cells. Drug induced. What does amiodarone have in its structure? Does anybody know? Does anybody know what this drug is? What kind of medication this is?
It is used for the I don't know how to say that in English, but tachyarrhythmias.
Great. Yes. Yes, you're right. And what do you know what this medication has in its structure?
Um, I'm not pretty sure, but I think that cetonas, maybe.
Okay, mainly it has high concentrations of iodine. Okay, so some drugs or some contrast mediums have a lot of, well, have high concentrations of iodine. So this one, which is, as you said, related to the therapy of some arrhythmias, right? And some sorts of contrast, since they have a high concentration of iodine, they could also cause hypothyroidism. Okay, so we also have this congenital cause, which would be related to altered gland formation. Uh, this gland would not be formed at all, or would have like this gland is not much does not get mature enough, and it wouldn't be able to work. Okay, so that's another way of getting this disease, and some other diseases like amyloidosis and sarcoidosis. Does anybody know what amyloidosis is about? So, Brisa Montoya, are you here?
Yes, I am.
Okay, so do you know what amyloidosis is about?
I think it's the accumulation of that protein.
Yes, the amyloid, right?
Yes.
What kind of organs would it damage besides the thyroid gland?
Mm, the heart,
Okay, yes, cardiac amyloidosis. What else?
the kidneys.
Great, yes. And any other?
Oh, I don't know. Maybe. No, I don't know.
Okay, great. You're right. The liver. Okay. And do you know any kind of stain it would be diagnosed by? Does anybody? Well, do you know what a stain is, right? In Spanish, tinción. Tinción. Do you know any kind of stain that you would ask for to diagnose amyloidosis?
uh, no.
Okay. Uh, Anybody? Danitza Burgoa? You can tell me in Spanish, guys.
I don't know.
Okay. Danitza Zambrana?
I'm not sure, but tinción de gram.
Actually, gram stain is for bacteria, right? Okay, Constanza, are you here?
Yes,
Okay, do you know any kind of stain that would be related to the diagnosis of amyloidosis?
uh, not really.
Okay, Diana, I know that you already participated, but I want to know if you know this.
No, I'm sorry.
Okay, okay. So it's I'm going to say it in Spanish for you to look for it, okay? Tinción Rojo Congo. It has like a unique name, right? Tinción Rojo Congo. like the country, right, in Africa. So if you asked for this kind of stain, uh, you would have a diagnosis. Well, this protein that is inside this, the organs that it affects, as your classmate just told us, like the heart, kidney, liver, right? You would ask for this kind of stain, and there you would have your diagnosis with this stain, okay? Tinción rojo Congo, okay? Weird name, huh? So this is the most useful part for all of you, right? Because the rest you already know. So we're going to take a closer look to symptoms and signs related to hypothyroidism. Does anybody know what hoarse voice is? Hoarse, right? Marcela Guzman.
Could you repeat it, please?
Okay. Do you know what hoarse voice is? You are seeing it on your screen?
Would be like a raspy voice or something like that, I
Yeah.
think.
Yes, great. So patients with hypothyroidism have this kind of voice, right? Hoarse voice, okay? Cold intolerance and weight increase. So let's go on. Integumentary is actually, can anybody tell me the term in Spanish, integumentary? And what it is related to, what kind of structures this is related? Integumentary. Mariana Sanquines.
Yes, that.
Okay, could you tell me what integumentary system is and what kind of structures it is related to?
Uh, well, I don't know if I'm wrong with the description, but integumentary system is about all that is external, like about the skin, uh, that is the uh, bigger organ in our body.
Okay, the biggest, right? Okay, bigger is like to compare, right? And EST is the most. So that's what you're referring to, right? Like the biggest organ, yes. So it is actually, you're right, related to the skin, the nails, the hair, right? So according to, well, when we're referring to hypothyroidism, we have, well, this patient might have a wet and dry and cold skin. And when mm, when related to hair, this person would have a weak and dry hair. Does anybody know what the madarosis is? Okay, let's make you participate. Paola, are you here?
Yes.
Okay, Paola, do you know what madarosis is? This one right here.
I think that is in the eye. Um, it's a lack of eyebrows. Uh,
Yeah, yes, you're right. It's like the external third of the eyebrows get lost, right? Like they fall down. Yes, so integumentary system, we would have that. Hematologic hypothyroidism, we would have, well, there are some types of anemia that a person with hypothyroidism would tend to have. Like normocytic and normochromic anemia. We already know what this is, right? Normocytic and normochromic, megaloblastic anemia, and iron deficiency anemia. Why do you think a person with hypothyroidism would have a normocytic and normochromic anemia? I didn't tell you, right? Sorry, I'm going to go backwards. So, when we're talking about causes, when we're talking about the immune cause of hypothyroidism, the most common disease is actually Hashimoto's disease. Okay, so here we have normocytic and normochromic anemia. Does anybody know why this person might would have this kind of anemia? Valeria?
Not really.
Okay, and when we have an immune process, an autoimmune process, there's like it's well, this person's immune system causes an inflammation, right? In this case, related to the hypothyroidism, right? To the thyroid gland. So there's an inflammation of this gland first because of the immune process. Okay, so this inflammation actually is related to some. I'm going to say it in Spanish for you to answer me. I know that some of you will. Reactantes de fase aguda, right? Does anybody know what these molecules are all about? And where, if you could tell me some of them, it would be great. Anybody? Reactantes de fase aguda, guys. What are these? In Spanish, guys, come on. Okay, let's get started with the list again. Okay, Bernardo, are you here?
Yes, I don't have idea.
Really? Okay. Brisa, reactantes de fase aguda. Oh,
I think those are the ones related with the inflammation, maybe.
okay, yes, great. And what molecules are related to this? Do you know?
I think the principal one is the C protein.
Great. Yes, that is the most known one, right? And that is the what we daily ask for. Okay, does anybody know any other? About any other? Constanza, do you know any other molecules?
No.
Okay, Danitza, Burgos?
El fibrinógeno.
Yeah, great. And there are like two or, yeah, and there are a few more. Great. Danitza Zambrana?
Alfa 1 antitrypsina.
Awesome. Yeah. And there's one that you might not have heard about. Epsidin. Does anybody know what epsidin is? Hepcidin. Epsidin. Okay, this is also uh, one of these kind of molecules. Okay, which is inside. Well, it's in the membrane of some cells. the macrophages. Okay, so as you know, the iron is actually distributed in three main compartments, and one of them is the ferritina, right? Ferritin. This one is inside these cells, and when there is like inflammation or infection, this epsilon molecule increases. Okay, so what is the main function of this hormone? Sorry, this molecule. To It's like stops another molecule which is in the cellular membrane of the cells, that is like a way through out of the cell. Okay, so iron, which is inside the cell, can go through this molecule to go out and join another molecule, which is transferrin, right? So this epsilon, it's like a blockage in that pathway. So ferritin increases, like the iron that is related to the reserves of the body increases, right? Because it cannot go out of the cell, but the cell cannot reach the bone marrow, so it's like there's little iron left to create new red blood cells. However, the red blood cells that are formed are actually normal. So that's why we have a normocytic and normochromic anemia. So, as for cardiovascular symptoms and signs, there would be a low cardiac output. Can anybody tell me what cardiac output is? Diana, it's your turn now. You're up. Marcela Guzman. Mariana Sanginés. In Spanish, even in Spanish, guys.
In Spanish, it like gasto cardíaco.
Great. Okay. So there's a lower cardiac output, right? There's also bradycardia, pericardiac effusion, and this patient would tend to have hypertension also. So what is an effusion? Can anybody tell me? Okay, an effusion is like a pleural effusion, the rana pleural, right? In this one, a pericardiac effusion. Okay, it's like they resemble each other. Okay, when we're talking about the respiratory system, this person would have chronic rhinitis, ventilatory disorders due to the decreased function of the respiratory muscles. In the renal system, there would be a decreased GFR, right? Can anybody tell me what GFR is? Glomerular filtration rate, right? So next, gastrointestinal, this person would be constipated and would have like a decreased sense of taste, right? When we talk about the reproductive system, this person would have a decreased libido, erectile dysfunction, and oligospermia. According to the neurologic sphere, this person would have decreased mental agility, memory, and depression. Related to muscular, there would be muscular stiffness and muscles and joints pain. Okay. So how do we how can we diagnose this hypothyroidism? As I told you, primary hypothyroidism is related to the gland itself, right? And secondary and tertiary hypothyroidisms are related to the pituitary gland and the hypothalamus, right? So when we ask for some laboratory studies, how would the primary hypothyroidism show us its laboratory levels? TSH would be increased and T4 is lower than usual. And T4, you know, the T4 and T3 are actually formed in the gland, right? In thyroid gland. So that is why when we have this lower T4 and higher than usual TSH, we're talking about primary hypothyroidism. It's like since the gland is not functioning normally, it would it would need stronger stimulation through the TSH. So that is why this TSH is increased. However, since the problem is in the gland, it does not work properly, so it produces lower levels of T4. Okay. Secondary and tertiary hypothyroidism is different because TSH is produced in the central nervous system, right? And actually in the pituitary gland. So when we have a lower than usual TSH, we would have decreased response by the gland. So TSH lower than usual and T4 lower than usual, then we are talking about secondary or tertiary hypothyroidism. And there's a variant here, the subclinical hypothyroidism, right? In which the TSH is actually higher than usual and the T4 is normal, in normal ranges, okay? This normal concentration of T4 is why we do not have some classical clinical features, right? So this person would not have any kind of symptoms or signs related to hypothyroidism. And it's like the diagnosis is actually hidden, right? It's like, it's difficult because this person does not have any symptom or sign, right? But if we ask for the TSH level, it is increased. Okay, so if you have higher levels of TSH and normal levels of T4, we're talking about subclinical hypothyroidism. So if the gland is not producing these hormones, we have to replace with exogen hormones, levothyroxine, right? Or T4. Like it's like T4. This is an isoform, right? Actually, the chain is actually on the left. That's why this is levothyroxine, right? The R chain, right? So we give our patient this medication, T4, exogen T4, of course, and it has to be taken in the morning with the empty stomach, and the dose depends on the age, the weight, and some comorbidities. The starting dose for a young healthy adult is between 1.6 and 1.8 micrograms per kilogram per day. And if our patient is over 60 years, the starting dose is actually 50 micrograms per day. So do you have any questions, guys? This is the first topic that we talked about. Let's get to the next one, okay? Okay, you see my screen, right?
Yes.
Okay, thank you. Let's get to the gastroenterology topic. I chose an easy topic, which is achalasia. Okay, this is really easy because some other diseases are actually a little more difficult to understand. And they're more complex, actually. So this one is easy and for you to understand. So what we're going to talk about here is, well, we're going to discuss a little anatomical review, the basics of anatomy of on the anatomy of esophagus, a physiology review, which would be the basics on physiological concepts, and achalasia concept, diagnosis and treatment of achalasia. Okay, so let's get to the anatomical review about the esophagus. So we actually have different layers, right? All the way through the esophagus down to the large intestine, right? And we have some common layers, which are the mucosa, submucosa, muscularis propria. Actually, there was a missing R here between the P and the I, and the serosa. Okay, so the mucosa has three main layers also: epithelium, lamina propria. There's a missing R also here, and the muscularis mucosa. And the submucosa has the Meissner's plexus, right? The in Spanish would be, as you already read about, the plexo submucosa de Meissner, right? And in the muscularis propria, we have the circular muscle layer, the Auerbach plexus, and longitudinal muscle layer. Between those two muscle layers, the circular and the longitudinal, we have the myoenteric Auerbach plexus. In Spanish, plexo myoentérico or myoentérico de Auerbach, right? And in this serosa layer, we have the serosa or adventitia, okay? And here we have what we were talking about. Okay, so here we have the external and the internal muscular layers, right? The circular and longitudinal layers, muscular layers, and in between of those two, we have the Auerbach plexus. So here we have the circular layer, and here we have the longitudinal layer, and between these two, we have the myoenteric plexus or Auerbach plexus. As you know, this plexus is actually called myenteric because these neurons right here supply innervation for both layers, the circular and the longitudinal layers. So these neurons are actually motor, right? So let's take a look at the physiology. So as you can see here, there are uh, peristaltic waves, right? Here we have primary, secondary, and tertiary peristaltic waves. Can anybody tell me what the primary peristaltic wave is all about? Okay, I see on my screen, I see. Okay, it's going to be random choice. Okay, Danitza Zambrana.
Can you repeat the question, please?
Yeah, sure. Could you tell me a little bit about the primary peristaltic wave?
Okay. The primary peristaltic wave is when the helps to move for, forward.
Okay. Yes, Paula, you raised your hand, right?
Yeah, the primary peristaltic wave helps to move food forward.
Okay. And what is the difference with the secondary peristaltic wave? Because it also helps move the bolus, the food. They both help moving the bolus, as you can see here. Okay, the primary peristaltic wave is actually a continuation of the deglutition reflex. So we swallow, right? We swallow when we're eating, we swallow, and we have the last part of the deglutition function is actually the deglutition reflex. So its continuation down the esophagus is a primary peristaltic wave. A secondary peristaltic wave is actually when, let's imagine right here. Sorry. For example, when we eat something like really, really dry, like a piece of bread, right? It stucks in our esophagus. So it makes the walls of the esophagus dilated, like right here, right? And it stucks, it's not moving anymore. So the primary peristaltic waves cannot move this stuck food. So when the walls of the esophagus are dilated by this piece of food, there come the secondary peristaltic waves, which start in the body of the esophagus. So the primary peristaltic waves is a continuation, as I told you, of the deglutition reflex. However, the secondary peristaltic wave does not need deglutition to start. So secondary peristaltic waves start when there's a piece of food that is stuck in the esophagus, okay? And it does not need deglutition for it to start. And what about tertiary? Can anybody tell me what the tertiary peristaltic wave is? It is actually pathological, this one. And that is why tertiary peristaltic wave is not actually peristaltic. However, some authors take into account this one. Okay, it's like this tertiary peristaltic wave, which is actually not peristaltic, is related to some sorts of diseases. Okay, when there is no food inside the esophagus, its muscular layers contract with no stimulation, no dilation from a piece of food, and no continuation of the deglutition reflex. Okay, that is a tertiary peristaltic wave. So here we have another diagram in which we are going to, by which we are going to understand achalasia much better. So here we have interneurons. You know what an interneuron is, right? So an interneuron is actually a neuron which inhibits some other neurons, right? So here we have this, these neurons are interneurons. When, well, these neurons are actually in the mesenteric plexus or the Auerbach's plexus, okay? So when the foot is going down, right? Like here we have the direction from oral to anal, right? That is the normal progression of food, right? So when the foot is going down its normal way, these neurons, which are the interneurons, descend down to the lower esophagus sphincter and make it relax. So the bolus, the food, can go from the esophagus down to the stomach. Okay, so when there is an stimulation of these interneurons, the normal and the physiological response is to relax the lower uh, esophageal sphincter. So the food can pass through this sphincter. Okay, and when there is a disease, so here we have what the main cells related to this disease are. So when there is achalasia, these interneurons are destroyed. Okay, and this normally produce this first two ones, nitrogen oxide, right, and VIP, which is in Spanish péptido inhibitorio vasoactivo, right? So these both molecules make the lower esophageal sphincter relax, so the food can go to the stomach, right? So in achalasia, these interneurons get destroyed, and there is no cell that can produce these both molecules. So the sphincter, the lower esophageal sphincter, never relaxes. So food stucks in the esophagus. So what is actually achalasia? Well, the name of the disease actually comes from two words. This one, right? A, which means without, right? And chalasia actually means relaxation. So without relaxation of a structure, which is actually the lower esophageal sphincter, right? So the lower esophageal sphincter never relaxes because of the destruction of the interneurons of the Auerbach's plexus. So there's a lack of the inferior esophageal sphincter. And this is like, well, since it never relaxes, the food is stuck up here, right? In the body of the esophagus. So what clinical manifestations or clinical features could we find in a patient who has this kind of diagnosis? This is the main one, conduction dysphagia. As you can see here, we have a knot, K-N-O-T, right? Knot. In Spanish, nudo, right? It's the patient tells us that feels like a knot in his chest. Okay, what is conduction dysphagia? Can anybody tell me the meaning of dysphagia?
Is when you can't swallow.
Great, difficulty when swallowing, right? So we have, according to physiology, we have two main types of dysphagia. Here we have one, which is conduction dysphagia. And what about the other one? Can anybody tell me? We already talked about it in some other class. Okay, can anybody tell me? Okay, it's transference dysphagia. Transference dysphagia is actually when a patient has some trouble starting to swallow. Okay, so it is related to higher structures, like when you have inflammation of your tonsils, for example, when you have an infection in your tonsils, right? It makes it difficult to swallow, right? So that is transference dysphagia, okay? related to higher structures. On the other hand, we have conduction dysphagia for, well, it is related to the function of the esophagus, which is to conduct the food from the mouth to the stomach, right? So we have conduction dysphagia when we are eating and we feel a piece of food stuck in our chest, because you know this organ, the esophagus, is in our chest, right, inside our chest. So it's this piece of food gets stuck here. So the patient tells us feels like a knot in his chest, or feels like the food is stuck in his chest or her chest. Okay, and therefore this patient might weight loss. This patient would lose weight, right? But in a long term, and this is important, this is a long-term weight loss, okay? Because if this patient that has conduction dysphagia and loses weight rapidly, you would have to think of esophageal cancer, okay? In this case, in a long-term weight loss, you would first have to think about achalasia, okay? And this patient would also have cough at night. And can anybody tell me why this person might be coughing at nights?
Maybe because I have reflujo.
Okay, actually, reflux is like the containing of the stomach go back into the esophagus, right? However, here we have this dysfunction of the esophageal lower esophageal sphincter, so there is no reflux actually. The food that was stuck during the day, let's say this person ate the whole day, was eating like his or her breakfast, lunch, and all the foods during the day, but mm, none of them went into the stomach. They are like stuck in the esophagus, right? So as they are stuck in the esophagus, when we are laying down, we are in a horizontal plane. So this food that is stuck here would go into the airways, okay? And that would stimulate the reflex, which is the cough reflex, right? That's why this person would have a cough at night and not during the day. In a long term, this would cause pneumonia, okay? However, at the beginning of the disease, this person might be coughing at night because of the horizontal position that this person takes after before going to sleep. Okay, these are the main ones: conduction dysphagia, long-term weight loss, and cough at night. However, we have some others. Halitosis, like you already know what this is. Here we have a diagram. Odynophagia, because well, this is odynophagia is like pain during swallowing, right? And it happens at the beginning of the disease, okay? And chest pain, this is not quite common. However, it could be present in some of your patients, especially if this patient has vigorous achalasia. Does anybody know what vigorous achalasia is? It's one type of achalasia. Okay, its name is already telling us, like vigorous. Its muscular layers contract very vigorously, contract very, very hard. So that contraction makes the chest pain appear. Okay. So here we have some X-ray features related to achalasia. As you know, when we are eating, when we eat something, it's normal to swallow some air, right? And when we swallow air and food, you know that gases always go above, right? Go up, and liquids and solids go down, right? So when we have an chest X-ray, a thorax X-ray, it's normal to have like the gastric bubble here, right? It is normal. We would have a gastric bubble here, which is like darker than usual. We would have like air up here in the gastric chamber. However, since the lower esophageal sphincter is actually not relaxing, the air that we are swallowing normally would not reach the stomach. So in a chest X-ray, we would not find the gastric bubble, which is normal. Okay. So when we give our patients some iodine or barium contrast, we ask the patient to swallow some contrast, and then we take an X-ray. And this is the result. This is here we have this study in which we can see a bird peak appearance, like a peak of a bird, right? The peak of a bird, also known as pencil sign, right? And there's another one I don't really remember right now. So here we have the dilated esophagus body, which is dilated, and then we have a pointy end of the esophagus, which is related to the lack of contraction of the muscular, sorry, lack of relaxation of the muscular layers, right? So this is the peak appearance sign. This is a sign, okay? Some other studies. Here we have a high resolution manometry, which is actually the most useful and the study that will give us the certain diagnosis. So we, as well, it's like an endoscopy test. We make the patient swallow this this item here, and it actually senses the pressure inside of the esophagus, and it will tell us if the pressure is above the normal ranges, and it will confirm our diagnosis. And an endoscopy test in which we might see a dilated esophagus body, right? And in some cases, we could even see rests of food that the patient had already eaten, right? And what is the the treatment? We have non-invasive treatment and we have invasive treatment. When we're talking about non-invasive treatment, we can give our patient this kind of medication, nifedipine, right? This kind of medication makes the muscular cells to relax, right? This is why this medication is also used for hypertension. So we can give our patient this medication to have his or her muscular cells related to the lower esophageal sphincter to relax with this medicine. Also nitrates, and these nitrates are also used in infarction, right? To make the muscular layer of the arteries relax. So the blood flow would continue as usual. In this case, we use it to relax the muscle cells of the lower esophageal sphincter. And then we have an invasive treatment, which would be related to myotomy, which is actually Hiller's myotomy, in which the surgeon actually gets rid of the muscular layer of this lower esophageal sphincter, okay, cuts it off. Also, we could all use this botulinum toxin, which is the A type botulinum toxin, in which we, or the surgeon actually goes with an endoscopy down to the lower esophageal sphincter and injects this toxin to make it relax. We could also use this other technique, which is the pneumatic dilatation. It's like an endoscopy test also. And it's like balloon that does not have air inside of it either yet. And when we reach the lower esophageal sphincter, we inflate it. We put air inside it, and we would destroy the fibers, the muscular fibers of this lower esophageal sphincter. However, this is not widely used because it would actually cause, in the long term, would cause reflux. Okay, so that would be it, guys. Sorry. Okay, so that would be it for today's class. I think it would be too much for us to continue with the third one. Tomorrow we're going to talk about a little about gynecology, okay? And then we're having our practice class. So if anybody has any kind of doubt, you can ask me now. Okay, so see you tomorrow, guys. If you can read a little bit about this, it will be better for us, okay? Before you leave, I'm going to show you the poll, okay? So here it goes. Let me know when you're done.
I'm down.
Thanks. Thank you. Okay, there's one more person who did not do it yet. Okay, I think we're done. Okay, thank you guys. I'll see you tomorrow. Have a good night's sleep. Bye.
I don't.
Have a good night.
Bye.
Bye.
Bye.